Hello everyone. Good evening. I am Dr. Puneet and today I will talk about cerebellar ataxia. Ataxia means loss of full control on bodily activity. So ataxia means loss of full control on bodily movement. It is a disorder of balance. Okay. So if ataxia occur because of cerebellar involvement, then it is known as cerebellar ataxia. Sometimes ataxia may occur because of sensory fibers involvement, then it is known as sensory ataxia, as in case of subacute combined degeneration or fidget ataxia, where patient actually unable to have complete feel of the earth, of the ground. So whenever it is dark or patient close his eye, his ataxia or sway worsen. Okay, so today I will discuss only about cerebellar ataxia. Now cerebellar ataxia, before going to the topic, little bit about the anatomy of cerebellum. Cerebellum, the flocculonodal lobe, it is its involvement lead to vertigo and nystagmus, and it is most commonly involved in medulloblastoma tumor in children. Okay, then if vermis is involved in chronic alcohol intake, or so here patient develop truncal sway, gait ataxia. So truncal and gait ataxia is there. And if lobe is involved, cerebellar lobe is involved, then it lead to limb ataxia. Okay, so patient sometime while eating he spoil his cloth, so loss of accuracy while eating, or buttoning and unbuttoning. Okay, so patient feel problem in his day-to-day activity. Now beside this, after this I want to discuss about signs and symptoms, how patient present to you. So ataxia patient, the most common complaint is gait difficulty. Patient is unable to walk properly, and sometime tendency to sway on one side or other. Sometime even truncal ataxia is there. Okay, tremor might be there, and in later stage patient may become bedbound, unable to walk. Okay, so frequent fall are there in later stage. Okay, and now when you examine a patient of ataxia, generally ataxia patient examine in 5 domain. Firstly, see his or her eye. So in fixed gaze, if saccadic intrusion is there, it is known as square wave chair. So check initially patient gaze, fix patient's gaze, and if saccadic intrusion is there, if it is this square wave jerk, and then suddenly says that look at right, look at left. In some SCAs, especially SCA2, there is slow saccades. Okay, so eye. Then second domain is speech, scanning speech is there. So in ataxia patient, scanning speech might be there. So unnecessary pause, scanning speech, okay, is there. And then gait ataxia. In gait ataxia patient sway toward one side or other with frequent fall is there. Limb ataxia, you check with finger, nose or finger test. Gait you may check with tandem walk in initial phase, and in later stage patient is even unable to stand properly. He stand with wide base gait, if at all he can stand. Okay, then after this what is the etiology? So after searching the signs and symptoms of ataxia, सर्च फॉर एटियोलॉजी. भाई इसको हुआ क्यों नहीं चल पा रहा है या क्यों बैलेंस नहीं बना पा रहा है, वाई हिज सेरेबेलम इज इन्वॉल्व. सो सपोज presentation is acute, So in acute presentation, the most common cause is alcohol. Okay, so it might be there that patient take alcohol and he is ataxic at that time. Sometimes some anti-convulsant drugs like this phenytoin, phenobarb, even metronidazole, or sometime even TB की दवाएं जो ATT में INH in patient with renal failure may lead to ataxia. Okay, and after antipsychotic lithium is very well known for this ataxia. Sometimes chemotherapeutic like 5-fluorouracil may also lead to ataxia. So these are cause of acute ataxia. It may be sudden in case of vascular, as I already discussed. If there is involvement of pica, ICA or SC artery, so superior cerebellar. So if posterior inferior cerebellar artery is involved, then patient have ataxia and dysphagia dysarthria. Okay, due to 9th and 11th involvement. If suppose ipsilateral ataxia is associated with facial paralysis, unable to close eye, tearing and drooling of saliva from the angle of mouth, then ICA involvement, then it is anti-inferior cerebellar artery syndrome. And suppose if there is only isolated ataxia, no dysphagia, no facial paralysis, there may be some deafness because of involvement of medial lemniscus, then it is SCA syndrome. Okay, so search for these causes in case of acute ataxia, sudden onset ataxia. And then subacute ataxia, in acute ataxia in children, sometime after varicella zoster virus infection, patient may develop ataxia. Few children comes to our OPD with ataxic gait, and it occurs and when we take history of rashes, so varicella rashes preceding history might be there in patient present with acute onset ataxia due to immune and patient responds very well to steroid. Okay, then after these subacute causes, nutritional and then demyelinating. In nutritional, B1, B12 or vitamin E deficiency. Sometime alcoholic patient may develop this nutritional deficiency and lead to ataxia. Okay, so these nutritional causes might be there in vitamin E deficiency, ABVD, or A-beta lipoproteinemia might lead to vitamin E deficiency, and Friedreich ataxia type syndrome means there is cerebellar ataxia, sensory ataxia, and plantar extensor might be there. Okay. Then after this demyelinating causes might be there in subacute ataxias, but here remitting relapsing history may be there in case of multiple sclerosis, or other causes are immune ataxias, especially anti-GAD antibody or these gluten sensitive enteropathies where GI symptoms precede ataxia. GI symptoms may also precede ataxia in case of Whipple's disease, where oculomasticatory myarrhythmias may be there. Okay, ocular masticatory myarrhythmias are there, and then then paraneoplastic history of weight loss or loss of appetite might be there in paraneoplastic cerebellar degeneration or paraneoplastic variety of cerebellar ataxias. Okay, then chronic ataxias. Chronic ataxias mostly degenerative inherited ataxias like autosomal dominant SCAs are most common, and in autosomal recessive Friedreich ataxia. Overall inherited ataxia, Friedreich ataxia is most common type of ataxia which occur in age less than 25 years of age, and history of cardiomyopathy, conduction block, for which edaveron is might be given, and this here history of diabetes may be there, so you may get polyuria, polydipsia, polyphasia history in case of this fluid ataxia, or even in autosomal variety ataxia telangiectasias. But in ataxia telangiectasias may be there, and recurrent respiratory tract infection because of immunodeficiency, IgA and IgG deficiencies might be there. And in ataxia telangiectasias you may find elevated alpha-fetoprotein. Elevated alpha-fetoprotein you may also find in ataxia with oculomotor apraxia. Oculomotor apraxia means in a fixed head, patient is unable to initiate saccades. Okay, means suppose if his head is fixed, so उसकी आई मूव ही नहीं करेगी. So उस आई मूव कराने के उसको हेड पहले टर्न करना पड़ता है, then only I move in case of oculomotor apraxia, ataxia with oculomotor apraxia. Okay, then in chronic ataxias, hypothyroidism is also an important cause. Among drug, amiodarone may lead to chronic ataxias. Okay, so these are other causes of these chronic ataxias. Now, how will you diagnose these ataxias? So go for serum level of vitamin B1, B12, vitamin E level, and suppose subacute onset is there, or history of weight loss is there, so onconeural antibodies may be checked. Okay, and if history of abdominal symptoms are there, so search for this gluten sensitive enteropathy, and okay, and then beside all this, MRI is an important diagnostic tool. In MRI you may find cerebellar atrophy in degenerative ataxias. Vermian atrophy might be there in alcoholic degeneration. Okay, and MCP hyperintensities, middle cerebral peduncle hyperintensities may be there in Fragile X tremor ataxia syndrome, where tremor is also there along with ataxias, and Parkinsonism features may be there. Okay, and then sometime degenerative ataxias which are not inherited, such as idiopathic late onset cerebellar ataxia or MSA, may be a cause of these cerebellar ataxia. In multiple system atrophy, although Parkinson type is more common than cerebellar, but in cerebellar type, patient have significant ataxias along with pyramidal tract involvement, along with autonomic involvement. Recurrent syncopal attack might be there, and in MRI you may get hyperintense putaminal ring or hot cross Burnside, that is cruciform hyperintensities in the pons. Okay, so now treatment, just treat the cause. Treatment for is not available for all type of ataxias, and suppose if you get cause such as vitamin deficiency is there, or stroke is there, ACA, SCA, PCA territory, so treat accordingly. If a patient having nutritional deficiency, then fulfill that. And suppose onconeural paraneoplastic ataxias, give IVIG, primary tumor surgeries, and in SCA. In SCA, actually, some studies are there for with valproic acid, and in episodic ataxia, some studies are there with 4-aminopyridine, but not very good result with these. Sometimes transcranial magnetic stimulation might be given for 2 weeks, which shows improvement up to 3 months, but okay, and gene therapies also explore in case of these degenerative ataxias. Okay, so that's all about cerebellar ataxias, and next time we will start with some new topic. Okay.